So Nick, you've been looking at integrated care in many places around the world, and you've seen many versions of implementing it. So what does it mean to you?
If you think about it, in today's systems, they're really failing people in many different respects, particularly older people with complex care needs. And the fragmentations in today's systems really make it very difficult for certain cohorts of people to live independently and live active and healthy lives. And this is due to a number of different reasons. It's partly because there are lots of different providers and professionals in the system who are providing care in silos. They're not coordinating efforts. And at the same time, people are having to manage their own care without the support and the ability to be able to do so. So integrated care in that sense really means overcoming those fragmentations and supporting a process where you have a person-centered approach that coordinates care around their needs, enables them to live more independently, enables them to manage their chronic illnesses more appropriately. It means they have less need for institutionalized care or specialist support. So it's all about that process. It's about getting the care when they need it and supporting them to live well.
A lot of people will like the idea of integrated care and integrated health system until they actually come to make it happen for themselves. So what are some things that a clinician or a health service manager can do with their own clinical team and with their own practice as a starting point to make it happen?
I think there are a number of prerequisites for doing integrated care well in primary community care. And the first one is that you need to be able to create a strengthened primary care service where GPs are working in a team-based environment with advanced care nurses or other professional roles who are supporting them to manage people with complex needs more effectively. Because these individuals require more than just a medical consultation. They might require support with assisted living in the home. They might require help with a mental health issue. It might be not just related to the patient, but also their carer and family. There are all sorts of things that influence the ability of a person with chronic illness to manage their own care. And unless you're working in a team-based environment, then it becomes more problematic for a GP to be able to provide all of the response that is necessary to support that person. So this requires a number of different capabilities. It means, on the first hand, being able to find someone who's able to go into a person's home or to be able to provide some sort of support to enable them to understand how to live with their condition, to understand how to manage their medications, to potentially get some support from peer groups or others in the local community who might be able to support them outside of a clinical consultation. But at the same time, it's the GP's ability to be able to extend their primary healthcare team, work in networks with other organisations in order to be able to draw down that additional support in a way that can do it. And it doesn't have to be rocket science. It can be really quite simple. And GPs do integrated care all the time. What we're talking about in our version of integrated care for someone who has complex needs is that you need to have a range of other services and a range of other professionals available to do it more effectively for the people with those complex chronic illnesses.
Nick, earlier I've heard you talk about the importance of that multi-agency, multidisciplinary team involved in someone's care actually meeting face to face, and how it doesn't really work with just a phone call or a web portal of shared messages.
What the evidence tells you is if you're just relying on a GP's clinical knowledge of a patient who he or she sees over time, yeah, or if you're just relying on data that comes out of a clinical system that suggests someone's at risk of a hospitalisation or a fall, this isn't really enough to understand the context in which a person needs support. So if you can bring together a team that might involve the GP, it might involve some information that's on a system, but it might support a community health worker or a nurse. The more you're able to have a case discussion that is multi-professional, that looks at the issues from lots of different angles, the better you're able to make a decision about what's necessary, so that you don't overtreat, you don't undertreat, that you're able to put in an effective care response that also takes into consideration, the client's wishes, is what they have possibly said to you, what they want and don't want. So that face-to-face meeting, I don't think there's any substitute for it.
We've sometimes talked about needing to, as clinicians, do a good clinical job for our patient and also do work to make our clinical team function well. And now we're talking about doing work to make the broader health system be able to function optimally for that patient's needs.
Yes.
So that's extra kind of work without necessarily extra money, and doing work for other people who are going to be paid differently. How do you motivate people to do that?
Well, the first motivation is that you're doing the right thing by your patients. So if you're running a practice that has these added capabilities, they're probably more likely to sign up with you, because you're managing them in the kind of like a medical home type model, and that can be very attractive to a number of patients. So on the one hand, there's an advantage there in creating a practice that has those capabilities, so you get more people wanting to come and register with you. The second thing is, if you're going to start to work with others in this kind of system, there needs to be a process where there's a mutual gain. So if you are indeed spending more of your time or more of the practice's resources in developing new capabilities, that has to be recognised. So there's no point in moving down this direction unless there is some sort of financial compensation for that. But it's not just about finances, it's not just about better patient care. There are other things that can motivate clinicians as well to get involved, and that's the opportunity to have a better work-life balance, because you're bringing in a nurse complement that's managing people that you don't necessarily need to see in a way that you trust. It could be related to the ability for you to have time to specialise in a certain area, to work in a network where you can have educational opportunities. There are all sorts of different things that might motivate a clinician to get involved in a team-based environment that allows them to do other things that they couldn't do in their own practice. And it won't be for everybody, and we need to recognise that part of the process is that you have to strengthen the ability of primary and community care to do that, which will require investment and therefore money, but it's not the only thing that will motivate clinicians to take part.
Sometimes in talking about integrated care, people get stuck on waiting for a big funding solution or waiting for a big bells and whistles IT solution. But are there some simple low-tech and low-cost things that we can be getting on with?
The secret here is high-touch, low-tech. And any form of information system is just a tool that might support you to be able to do things more effectively. It's a tool that can help you support better communication between clinicians so that you can get the decision support that you need more effectively. It's a tool that you might be able to understand the needs of your local population so you can drill down to the people who might be most at risk of a hospitalisation. It's a tool so that you can compare case notes as to whether your referral process has been more appropriate. But they're just tools. Fundamentally, what makes a difference in integrated care is the ability to be able to have hands-on care with the individual to be able to manage that process. And I see too much emphasis often that's placed on creating an expensive and all singing and dancing ICT system, because all it is a tool. And if you haven't actually made the decision that you want to work in an integrated care fashion, or you want to support chronic illness management in the home, or that you're prepared to work differently with other colleagues in order to support that type of approach, then any form of information system is not going to work effectively, because it's only providing you with a capability, it's not providing you with a new way of working. So let's take the example of a typical approach. So you would identify individuals who come to your practice who might be most at risk, and you decide that they might need some form of care assessment or someone who goes into the home to check out what's going on. The more that you can make that process a two-way process, so that care assessment process and the subsequent care plan that might emerge is also a way in which you can connect with that patient or the carer and their family to make them understand what they need to do to live in a safer environment, or how they might get the understanding of how to manage their medications better, or have other forms of tools where they can connect in with other people who've got a similar problem that they can learn from. The more that you can create that social connection and that form of personal continuity of care to the individual, the better, really. And what you find is that if systems of that care planning just means you're taking away that information and you're putting it into an ICT system to run an algorithm that leads to an understanding of what the care plan should be in terms of a medication regime or a treatment protocol, you miss 90% of the equation. So you're absolutely right. The whole purpose of this new approach is to invest in a new type of relationship with the patient that leads to a long-term management of their care, and that means providing or developing an approach to make the patient more activated in the management of their own care and feeling more confident to be able to do so. It's a different type of dialogue and relationship.
So having looked at integrating health systems in many, many settings and over a long time, what do you see as the key ingredients to make it happen?
Well, there are many, but I'm going to boil it down into 7 key things. And this is particularly for people who have multiple chronic illnesses and age-related frailty. And I think the first 2 things are all to do with population health. And the first thing is, in order to be able to manage older people with complex needs in a community better, you need to have a really explicit understanding of those individuals or those families who are at risk or who need support. So you need to have some form of system, whether it's through information or through regular monitoring, that gives you an early warning system. Targeting the right people so that you understand who they are and how to address it. Because if you don't have that, you're either you're fishing in the dark, and actually you might put all of your efforts in the wrong place and you can waste a lot of resources, or you miss people. So you need to have that capability. The second thing is to focus on empowering people to manage their own care. It's about health promotion and ill health prevention, and it's focusing on people to live independently. The third one is around
I was going to say that
care coordination.
Fits really well with Atul Gawande's saying that the patient is the most untapped health resource in the system.
And it's not just the patient, it's the community as well. So if you look at the context in which a patient is living with these chronic illnesses, all of the evidence would tell you that the outcomes that patient has, the more beneficial outcomes, are not related to a medical response. It's not related to the aggressive management of a chronic illness. It's not related to anything that can be done to cure a problem. It's about supporting a person to live well with the conditions that they have securely and safely. And that's a whole range of different social care issues around adaptive housing, around the issue of social isolation, about supporting people with mental health and anxiety problems, about enabling the carer to get the resilience to cope with that person they're looking after. These are the sorts of things that really will support a person to live well with their long-term conditions. And if we have too much of a medical mindset, then we don't see that. And part of the issue with that is, how do we engage the community, the friends and the neighbours, that provides an environment that enables a more healthy living environment for older people. And that is the untapped resource, not just the patient themselves, it's the community that can actually support that process. So if the first one is population health, understanding your population and targeting the people who you can influence most effectively, and the second one is supporting people to self-care and self-manage. The second one also presupposes investment in primary community care capabilities. The third one is around care coordination, and that's about supporting individuals with a whole range of different services that they need to manage their care well, and the sequencing of events that means they don't fall through gaps in care. That's quite obvious. And then a fourth one would be very much about the information systems that you have in place, so good communication between all of the different players who are providing the care. A fifth one would be around the ability to have a responsive service that's outside of those primary community care systems. And I might just explain that slightly. So most approaches to older people's care would focus on some form of care or case management. And usually you would find that the GPs would be working in collaboration with some form of multidisciplinary team that would enable case management in the home or in an intermediate care facility, step up, step down from hospital, something like that. But for the complex patient, they're always going to need something additional at some point, a specialist care input or occupational therapy or something that's outside of that team. Now, if your team is working in a really good fashion, but it's almost impossible to draw down these additional capabilities because the waiting lists are too long or the capability is not present, for example, in rural Australia, where it won't be, unless you've got a system whereby you can actually find a way to bring that capability in quickly enough, then the system falls down. It falls down. So I can tell you a lot of these care management schemes do not work because there isn't the capability in primary community care to respond to the complex needs of the person living at home. And you might put an awful lot of effort and money into it, but they'll end up having to go to the hospital anyway because they just don't have that capability to manage. So it's getting that balance right. So you need a responsive system from those outside of that core team. And you see that especially with care management schemes that don't run at weekends or in the evenings. Well, we know very well where people end up being emergency admissions. It's in the evenings and during the weekends because there needs to be some sort of response that's available in a primary care setting for that. So two other things maybe. One is we're still learning, so we need to have research and evaluation on two fronts. Firstly, to understand better the models of care that work in different circumstances, because there's no common answer to the problem. But more importantly than that is keeping monitoring and understanding how it works in your particular location, so that you can reflect on the way things are working and continually adapt. It's kind of like having a learning organisation, and I think too often we think there's a single answer to everything when there isn't. And a lot of the value of integrated care for the partners involved is going on a journey together over time, where you begin to understand and learn about each other, and actually the solution comes forward through that process of joint learning. So having the ability to have a learning environment to understand what is required is important. Absolutely, yeah.
So thanks again, Nick, for sharing those thoughts with us. We're trying to get on with that journey of developing our integrated health system in our local areas, and hopefully your experience will be able to give us some